السلام عليكم. بسم الله الرحمن الرحيم. الحمد لله رب العالمين والصلاة والسلام على سيد المرسلين. Good evening, ladies and gentlemen. It's my pleasure to welcome you in this scientific session. Today, actually, we have a very interesting subject that is we would like to share with you. The perspective is different. We have both an echo field and we have also the clinical part of it, which is, I think, is very important in this commonly seen disease. I am sure majority of you saw the recent edition of the European Society of Cardiology articles, which was really quite interesting. The interest on it, that is, they talk about two things: the importance of the classification of the heart failure based on the ejection fraction, which we used to have the middle range, which is between 40 to 50, and people are thinking now to change this. So I think it's very nice to have Dr. Alauddin Khalil, who's going to really to highlight the role of echo in assessment of heart failure. In the second part, we have also Dr. Hani Snober, who is, I think, well known to majority of you. He's an electrophysiologist and consultant cardiology involved in many registries with us, actually. And he also is going to share the pathophysiology of the heart failure with reduced ejection fraction. And I think he, again, this was a touch on the role of the microvasculature and the role of microangiopathy in the heart failure is a very important issue as well. So please share with me welcoming the two speakers. I am sure the session will be very exciting for you. So we'll start first with Dr. Alauddin Khalil, who is going to give us the role of the echo in assessment of heart failure. Thank you very much.
Shall I start?
Yes, please, go ahead.
Okay. بسم الله الرحمن الرحيم. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. I would like to thank Sylvie for this interesting meeting, and I hope all of you benefit from our lecture today. My topic will be role of echo in heart failure. As you know that given safety and easy availability and the ability to permit comprehensive assessment of the cardiac structure and the function, echo is an important tool in evaluation and management of the patient with heart failure. Heart failure is considered as a clinical diagnosis based primarily on the symptoms and signs. Aside from the brain natriuretic peptide, which is relatively useful for diagnostic feature, laboratory for the heart failure with reduced ejection fraction mainly, laboratory investigation traditionally not form a part of establishing the diagnosis of the heart failure. However, clinical diagnosis of heart failure is often challenging because symptoms and signs of heart failure are either too non-specific or too unclear. That's why the ESC guidelines on heart failure, they recommended the use of the echocardiography for the solid diagnosis of the heart failure, with class 1 indication for the echo. It is used to assess structure and function of the heart in suspected patient with heart failure to establish diagnosis of heart failure with reduced ejection fraction or heart failure with preserved ejection fraction. Also, they recommended assessment of the left ventricular ejection fraction in patients with heart failure for planning for the management, either pharmacological or device implantation or for the surgical. Also, they recommended by class 1 indication to assess the valve and the right ventricular function and the pulmonary artery pressure for the patient already established diagnosis for HFrEF or HFrEF. For this patient suitable for correction of the valves surgically and improve their condition. And lastly, also, they indicated the use of echo for assessment of the myocardial function in patients receiving medication, which can damage the myocardium, like patients receiving medication for the chemotherapy. So, echo role in the heart failure, it is used for diagnosis and also used for prognosis, and for therapy, it is class 1 recommendation from ESC guidelines. Why echo is important? Echocardiography provides data regarding cardiac structure and function. And also,
Sorry to
Yes.
disturb you, Dr. Ala. Can you just move your make your slide full screen?
It is not full screen?
No, it's half.
No, it's not full screen.
You can stop your sharing again and you can re-share again.
Just go to the PowerPoint and make it full, and then you share it.
Because it's full in my computer.
Now it is full. Now it is full screen, Ala.
Now full screen?
No,
Yes.
you need to share the screen, doctor. Yeah,
Yes.
just make it full.
Yes, press on this.
Now it's full screen?
No, still, doctor. It's half. Yes. Now it's clear.
Excellent. Now it is full. Thank you.
Okay, okay. So cardiography, it is important for the structure and the function of the left ventricle, and also it helps to identify the etiology, like structure versus functional, systolic versus diastolic, ischemic versus non-ischemic, and also important for quantify the abnormality and the selection of the therapy, and also follow up the course of the disease and the prognosis. For the etiology, the echo can be used for diagnosis of the valvular heart disease as a cause of heart failure, like stenosis or regurgitation. Also, for the coronary artery disease, by detection of the segmental dysfunction of the left ventricle, congenital heart disease by abnormality of the anatomy, and the pericardial disease if there is effusion or constriction, in addition to the hypertension with detection of the left ventricular hypertrophy, and the cardiomyopathy with composite cavity size measurement and wall thickness and contractility. To assess LV structure and the function by the echo, it is by different ways, mainly by the volume and the masses, which is now we are using with 3D echo in all our labs. It is more accurate than 2D echo, and also measurement of the ejection fraction, endocardial motion, wall thickness, and the transition from the motion to the deformation by the strain. And at the end of this lecture, we will concentrate a little bit about the strain and its role in the patient with heart failure. So the echo will be used for diagnosis, as we said. For diagnosis, it will help to classify the patient according to the ejection fraction. Either patient with heart failure with reduced ejection fraction, at the time will be ejection fraction less than 40%, or patient with preserved ejection fraction with ejection fraction more than 50%, or mid-range patient between 40 and 50%. All these cases or these patients will have the symptoms and signs of the heart failure, and also may be elevated level of the diastolic peptide. For the patient with preserved ejection fraction needs another additional criterion, which may be that left ventricular hypertrophy or left atrial dilatation, and also left ventricular diastolic function is very important for this patient with preserved ejection fraction. Also, there is importance for the for assessment of the left ventricular diastolic function in patients with heart failure with reduced ejection fraction, because it is important also to estimate left ventricular filling pressure, which is important also for the prognosis and for the management of the patient with the HFrEF. The approach for this is by mitral inflow velocity for the E wave and the A wave, as we are all doing daily in our laboratory. But this method, it will not be validated if the patient have atrial fibrillation, significant mitral valve disease like severe MAC, and also mitral valve repair or replacement, left ventricular assisted device, left bundle branch block, or ventricular paced rhythm. This is the way to assess left ventricular filling pressure, also by doing this pulse Doppler for assessment of the E wave and the A wave. And as you know that we are using this for the grades of the diastolic dysfunction, grade 1, grade 2, up to grade 4. And also another thing to measure is deceleration time for the E wave, which is important for the advanced cases of the heart failure, mainly restrictive type, If the deceleration time less than 160 milliseconds, it means that the patient going towards the restrictive type or restrictive physiology of the heart failure. Also, we are utilizing the myocardial velocities by using a tissue Doppler, which mainly putting on the septal side or the lateral side by also evaluating and measuring the E prime in these patients by tissue Doppler. This slide summarizes the echocardiographic parameters of the left ventricular dysfunction, which will be for the tissue Doppler, the E prime in the septal side will be less than 7 centimeters per second, and the lateral side less than 10 centimeters per second. Average of the E to E prime ratio more than 14, left atrial volume index more than 35, 34, and the peak tricuspid velocity more than 2.8. Also, this part, which is that E ratio of the E to E prime ratio, it is very important because by this also we can add 4 to the resulting number to give left atrial pressure, which is very important for the left ventricular filling pressure and showing that the progression of the heart failure. And left ventricular diastolic dysfunction by using that mitral inflow velocity, it is very important, as we said, for the grading of the heart, of the diastolic dysfunction. But you have to put in your mind that once the relaxation is started to be impaired, the left ventricular filling pressure will be increased, and it is more bad prognosis for the patient. So it is very important for following the patient from the diastology. It is important for the monitoring also for the management. As we said that echo used for diagnosis of the heart failure, and also ROX used for the prognosis and following the course of the heart failure, like the changing of the mitral flow, but optimized therapy. We look for this patient for the prognosis and the response to the treatment. Like this condition, if the patient at the beginning, at the base, it was grade 3 diastolic dysfunction, and after good anti-failure medication, it changed to grade 1 diastolic dysfunction, it means that there is improvement and it's proper management. But if the patient was at the base, grade 1 diastolic dysfunction, and went after 6 months on optimized medication to grade 3, it means that it's a worsening and with a very bad prognostic sign. So also it is very important for the echo, for the assessment of the therapy and also prognosis of the patient. As we said, for the ejection fraction the measurement nowadays in our lab, we are using 3D echo for assessment of the left ventricular volumes and the ejection fraction. And by one click on the heart modules in your machine, we can get all these findings, like end-systolic volume, end-systolic volume, stroke volume, and the ejection fraction. And it is proved to be better accuracy than to the echo, and also lower variability and validated against cardiac MRI. So it is more documented that it is more beneficial for the assessment of the ejection fraction. For the use of echo for the therapy, it helps to planning for your therapy, like medication, medical treatment, or device implantation like CRT and ICD, and also for the surgery if we detected that severe valvular heart disease which is causing heart failure at the time we are planning for surgery more than medical treatment. And also the guideline concentrated on the importance of the echo for the cardiac resynchronization therapy by all other criterion, and that, as I said, that there must be left ventricular ejection fraction less than 35% to be one of the criteria for implantation of the cardiac resynchronization therapy in spite of the optimal medical treatment. So role of echo here, it is very important for selection of the type of your management. Now we'll concentrate more in some specified things for the assessment of the echo for the heart failure. What is the role of echo in patients with heart failure and the preserved ejection fraction? I hope at the end of the lecture for all my colleagues can concentrate and can differentiate between concentric left ventricular hypertrophy, concentric remodeling, and the eccentric left ventricular hypertrophy, which is very important things. Why? Patients with HFrEF, which preserves ejection fraction, left ventricular myocardium generally respond by increasing the radial thickness of the muscle fibers, and this results in the increase in the left ventricular wall thickness and also increase of the muscle mass. So increase in the left ventricular wall thickness and together with the increase of the left ventricular mass, it will cause what's called as concentric left ventricular hypertrophy. In some cases, however, absolute left ventricular mass is not increased, but there is increase in the left ventricular wall thickness. So it's called as concentric remodeling. So concentric remodeling, it means that there is increase in the left ventricular wall thickness, but there is no increase in the total left ventricular mass. It is very important. Why we are bothering ourselves by these two categories? This is the distinction between these two entities. It's very important because concentric left ventricular hypertrophy is associated with much worse prognosis as compared to the patient with concentric remodeling. Another category also, which is called as eccentric left ventricular hypertrophy, it can happen if there is only left ventricular mass is increased without increase in the left ventricular wall thickness. And also it is very important for patients mainly with HFrEF, with heart failure and reduced ejection fraction. How can we apply this practically for practical point of view to decide about this? It is very easy by echo. If you do the echo and do what's called as relative wall thickness. Relative wall thickness is equal to multiplied by posterior wall thickness divided by left ventricular internal dimension at the end of the diastole. So it is this equation 2 multiplied by posterior wall thickness divided by left ventricular internal dimension at the end of the diastole. Normally it must be less than 0.442. And if it increases more, it will be increased if it is more than 4.2. If you are plotting this with the left ventricular mass, as we said before in the previous slide, let us look for here. If already the relative wall thickness it is normal and left ventricular mass index is normal, it means that it is normal geometry. So it is no problem for this. But if the left ventricular mass it is normal, but the relative wall thickness is increased, it means that the wall is increasing the thickness only, so it is concentric remodeling, which is very important. If the left ventricular mass index is increased and also this relative wall thickness is increased, it will cause concentric left ventricular hypertrophy. On the other hand, if the left ventricular mass index is increased but normal relative wall thickness, it means that it is eccentric hypertrophy. By this way, by the echo, in the practical point of view, you can differentiate between this patient and you know also the prognosis. Echo in heart failure with reduced ejection fraction. In contrast, the patient with heart failure with reduced ejection fraction has an elongation of the cardiac myocytes without no increase in the width. There is no increase in the thickness, only elongation. There is also fibrosis and the degeneration of the extracellular collagen, and as a result, there will be eccentric left ventricular remodeling with an increase in left ventricular cavity size without any increase in the left ventricular wall thickness. In spite of this also, it may be also left ventricular wall thinning. So in this condition, the left ventricular mass may be increased, and the increased left ventricular mass without increase in the left ventricular wall thickness, it means that it is eccentric remodeling or eccentric hypertrophy with increase in the left ventricular cavity. In addition to this, as the patient's left ventricular dilates, it tends to assume more spherical shape to accommodate more and more volumes. So, however, increase in the sphericity of the left ventricle, it seems to be maladaptive process because it increases the wall stress and leads to the greater left ventricular remodeling and is associated with poor clinical outcomes. So, once you diagnose that the patient has already eccentric left ventricular remodeling, and we can diagnose this, as we said, already there is increase in the left ventricular mass without increase in the thickness of the left ventricular wall. Once you find this and the patient have a spherical appearance, you go to what's called as sphericity index. Go to the sphericity index. How can we measure this? It is measured by already the left ventricular length divided by the diameter of the left ventricle. If it is less than 1.5, it means this, it is an abnormal. It means that the left ventricle it is going to deteriorate more and more, and you have to interrupt for the management of the heart failure of this patient. Also, by the usage of the echo for the diagnosis of heart failure, and it is very important, they highlighted also in the guidelines by class 2A indication that you have to use tissue Doppler, as we said, and also use deformation indices in the form of the strain and the strain rate, which should be utilized for the protocol for the patient at risk for the heart failure without developing heart failure. It is in order to identify the myocardial dysfunction in the preclinical stage. It's very important for this condition. What about 3D deformation of the left ventricle? Now, most of the our topics in the echo nowadays for the heart failure going to the 3D deformation and looking for the strain and the strain rate, which is very important. Left ventricle ejection is associated with unique pattern of the 3D deformation during the cardiac cycle, which is characterized by longitudinal and circumferential shortening and radial thickening, which is called as LV twist. Longitudinal and circumferential shortening with radial wall thickening called as LV twist. Endocardial fibers already is aligned more parallel to the long axis of the left ventricle, and it is responsible for longitudinal mechanics, where epicardial fibers responsible for circumferential mechanism. What about the radial mechanism? Radial deformation, it represents the sum of the subendocardial and subepicardial deformation in the radial direction. And it is very important for the rotational movement of the heart. Rotation is very important, and the twisting are unique properties of the left ventricular contractile behavior, and are very important in maintaining its normal systolic and diastolic function. How can we apply this clinically in our lab? By what's called as speed tracking. I will not go for details about these things because it's out of scope of our lecture, but just this is clinical application of this LV deformation by speed tracking, which is already was introduced later as a grayscale based technique for myocardial deformation imaging. Just I'll give you examples for how can you read this deformation, how you can read this strain. Very easy, simple on your daily practice. This already the patient with a strain, simply to say that by the eyeball, if the patient global longitudinal strain, which is a GLS, there is a specific number. All it is different with different vendor, but mostly agreed that if the number is more than in the number than -18, it means that -19, -20 like this, it will be normal. It will be normal global longitudinal strain. And if less than this, it will be abnormal. So for this example, it showed that already GLS, it is about 20, more than 20, -20, so it is normal in this condition. So what about the abnormality? How can we use this? To this strain, it allows for the evaluation of the global and the regional myocardial deformities. Like here, if you look here, what is this? Global longitudinal strain is -12. It means that it is less than -18. It is abnormal. But if you look here also, it has a specific distribution that already all here it is normal, but already have some segment which is very low longitudinal strain, which is the anterior and also going to the apex. So it is segmented. It means that it is going more with the coronary artery disease as the etiology for the heart failure. On the other hand, for the DCM, global longitudinal strain, it is very low, -4. And here also it is already widespread distribution of the low longitudinal strain. So it is going with diagnosis of the DCM, which is very important for etiology. But what about cardiomyopathy with normal ejection fraction? These 3 examples of the patient with normal ejection fraction by 2D echo. All have normal ejection fraction. For the normal person, normal ejection fraction is there. And if you look for the global longitudinal strain, how much it is? -22%. So it is normal. And also the distribution is normal. So this is normal person. What about apical Hockham? Apical Hockham ejection fraction by 2D echo, it may be normal or more than normal also. But here, if you look for the global longitudinal strain, it will already -19, which is within normal. But if you see the distribution, we will find that it is longitudinal strain, it is very low in the apical part, which is going with the apical Hockham. And for amyloidosis, it is already global longitudinal strain, GLS, it is very low, -7. But also there is a specific criteria for the amyloidosis, which is the sparing of the apical part, which is called as red cherry spot. So it is very characteristic for the patient with amyloidosis. This is also example how to interpret this strain. This is in the first forward. It's just looking here already that already global longitudinal strain is already very low, but sparing. This is the apical part which is going with amyloidosis. And in this example, showing that already the only segmental part, which is the septum, is affected, which is going with isolated septal impairment of the septal hookum. And the example, these two, it's showing that already patchy reduction of the longitudinal strain, which is present in the patient with aortic stenosis. The last part of my lecture, showing you some examples from our echo lab in IMC about the patient with heart failure and what we are doing. This is a patient came with a heart failure, and already the patient already presented with history of severe shortness of breath over the last 1 week. We discovered here, what is this? It is showing here complete echinacea of the left ventricular apex and also this part of interventricular septum. And if you look here, there is dropout points, which is very clear here in the distal part of the septum. And we put colored Doppler showing that there is a chant already from the left to right side, and the right side is already dilated. So diagnosis this patient as a cause of heart failure has acute myocardial infarction complicated by ruptured septum and development of the VSD. So from this part, by the rule of echo, we directed the patient directly to the surgical side for fixation of both coronaries and also correction of this this defect. This is another patient coming with heart failure, and we show that here. We found that symmetrical septal hypertrophy, decreased left ventricular volume already, and with presence of the SAM and increased velocity across left ventricular OT. Here showing that the SAM is very clearly in the M mode, and also the thickness of the asymmetrical septal hypertrophy, and with Doppler showing that late peaking of the Doppler at LVEF with dagger shape, which is specific for diagnosis of the hookum as a cause of the heart failure also. Another patient came with the manifestation heart failure. We discovered that patient has already rheumatic mitral stenosis with a large left atrium, and they referred the patient after the started medication, and they referred the patient for the surgical side to decide about his surgery of the mitral valve. And also this patient came after severe emotional distress with picture of heart failure. And the echo showed very clearly typical pictures of the Takotsubo with the hair, that apical ballooning, and also that severe hypokinesia of the mid and apical part, sparing the basal part of the patient. Already coronary angio was normal. Patient started medication, and after 2 weeks, it showed that improvement of the contractility. So here we can also diagnose that Takotsubo as one of the important causes of the heart failure. Also, it cannot be done except by the echo in this condition. Other patients came with the severe mitral regurg, and also have another regional wall motion abnormality in the left ventricular apex and lateral part and the part of the septum. So it is the cause for the heart failure could be here severe mitral regurg and also coronary artery disease, and directed the patient for the surgery. This is a patient also coming with global hypokinesia, severe global hypokinesia, and large pericardial effusion and pleural effusion. In spite of this large pericardial effusion, if it is per se, it can present the patient with the heart failure manifestation. But also it can also exacerbate the manifestation of heart failure if there is underlying pathology like the patient with DCM. And this patient, it is renal patient, came with severe heart failure. And at the time when we do echo, it shows that normal ejection fraction and concentric left ventricular hypertrophy, which is sparkling appearance of this myocardium, and also with doing for the diastology by the mitral inflow showed that already E to A ratio more than 1.6 and distillation time 130. So it is going with the restricted pattern. And also, if you look here, you will see that the ECG, it is low voltage in spite of the presence of the large L. So diagnosed as amyloidosis and confirmed by the presence of the also biopsy, and the patient started the medication as a cause of the heart failure. This also patient with heart failure discovered that has DCM and also complicated by large thrombus. It is very important for the echo. We started medication, started anticoagulation. And the last example here, it is a patient with severe aortic regurgitation, as diagnosed from here as already the already regurgent jet. It's to LVEF, it's more than 40%. And also, if you look to this, we'll look to the aortic arch. There is already flow reversal in the aortic arch. If you find that flow reversal in the aortic arch, it means that it's moderate or severe aortic regurgitation, and we look by this by the Doppler, which shows that hollow diastolic flow. And if you see that VTI here, VTI, if it is more than 15 centimeter, it means that it is severe aortic regurg. Here it is around, not 15, it is about 35 millimeter. And also deceleration pressure half time, it is around 150, which is less than 200, which means that it is severe. And also in this condition, we are looking for the abdominal aorta. You find that flow reversal also in the abdominal aorta. Once you find flow reversal in the abdominal aorta, it means that it is severe aortic regurgitation, as we saw here. So to conclude my lecture, echocardiography plays a key role in patients with heart failure for diagnosis, which is including the etiology, prognosis, prognostic stratification, and the treatment planning and monitoring. Also, newer methods like strain imaging may further has diagnostic aids, providing incremental information to the conventional ones. And also, there is a high diagnostic yield nowadays of the handheld and pocket echocardiographic equipment when used by experienced echocardiographic. We have our Echo Club group on the Facebook. Now it is growing. It's now increased, reaching about 1,300 members. And because of the COVID-19, we cannot do our competition as usual in our Echo Club thing. So waiting for us at the end of this month, we'll start our activity on this group with competition examples and also discussion with you. And at the end, I thank you for attending this lecture, and I hope that I could convey my message successfully. Thank you.
يديك العافية علاء. I think it was very illustrative lecture, well presented, and we really missed your Echo Club session. I think Alaa, mashallah, tabarakallah, is very active here in Jeddah. He's arranging a monthly Echo Club meeting. Hopefully, inshallah, we'll get back soon, or maybe you consider it as virtual. And I think this is very important to illustrate the echo. And now we move to a different aspect. Dr. Sabboor is really going to touch about the clinical implication of reverse remodeling in a patient with reduced ejection fraction. Dr. Hani Sabboor, as I mentioned to you, he's an electrophysiologist working in Emirates, and he is very active in the field of heart failure, hypertension, and hypercholesteremia. So please share with me in welcoming Dr. Sabboor.
Thank you very much, Dr. Kansara and Dr. Alaa. Really, it's a very brilliant opportunity for me to be invited to your esteemed meeting. I'll just start the slides now. So, if you'll permit me, I'll try to talk today about the phenomenon of reverse remodeling in heart failure with reduced LV function, and we'll have a practical approach with some two important case-based real scenarios. So I think the crashed a little bit. There we go.
No, we don't see the slide.
1 second. I think because of the videos, it sort of crashed.
You can.
Yeah, I'm doing it again. Yeah. Okay, here we go. Is this visible, Dr. Kansara?
Not yet.
Okay. Last time.
Great. Just make it full slide, please. Full. Excellent.
Okay.
Thank you.
Okay, so we'll move forward.
Yeah, great. Thank you.
So you're welcome. For more than a century, doctors have considered this clinical constellation of tachycardia. Again, a very critical point. We generally discharge patients when they are on a good dose of diuretics and they are euvolemic. The key point, though, that we should change our paradigm and mentally think, is the patient on lead to mortality? So the treatment of heart failure and reduced ejection fraction is not about fluid management nor diuretics. So remember an important point. If the patient comes to you in the clinic, they may tell you, if you ask them, are you having shortness of breath? No, I'm fine. But you have to ask them a direct challenge question. And that is, can you go up one flight of stairs? The patient will tell you, Doctor, I am a heart patient. I can't go up the stairs. I never go up the stairs. But that's the important point. Why don't they go up the stairs? Because they have reduced ejection fraction. They have reduced cardiac output. And this actually becomes not an asymptomatic patient, but in fact, truly a functional class 2 patient. And functional class 2 patients are at very high risk of sudden death and progression of disease because the patient deceives themselves and deceives the doctor by telling them I am asymptomatic. They're not asymptomatic. They have a reduced cardiac output that makes them unable to do simple activities of daily living, such as going up one flight of stairs. So please remember, this is a very simple clinical point that changes the paradigm. Do I need to do something for the patient or not? Now, a lot of these patients who have mild or lesser symptoms or admit to mild or lesser symptoms are because they know that if they walk, they will be fatigued. However, underneath this, these heart failure patients have 100 times faster damage than healthy hearts. This is called because of the increased overload, increased remodeling, vasoconstriction, and reduced cardiac output. And this increase, constant RAS activation, puts them into further danger. Now, the guidelines are fairly clear. This is the ESC guideline. And of course, if you follow the American guidelines also, you'll note that they're very similar, except in the structure. This is a serial approach. The American guideline is a parallel approach. Regardless, though, initial therapies with ACEs, ARBs, and beta blockers at target doses, and then adding MR antagonists. And then at that point, you have the ARNI, which of course, I think in the new guidelines is going to be moved up quite rapidly, as you've probably seen. Need for CRT and ivabradine if the patient's in sinus rhythm with a heart rate greater than 70. So these are the basic fundamentals. And of course, now we have the SGLT2 inhibitor with DAPA-HF being a leading study as an additional therapy. Now, coming to the remodeling aspect, and this is important. The remodeling is really due to progressive apoptosis, fibrosis, and hypertrophy. This caused by the initial damage, be it myocardial infarction or myocarditis or whatever, leads to increased overactivation of the systemic neurohormones. This in turn increases cardiac myocyte damage, further fibrosis and hypertrophy. Functionally, we get worsening change of the heart with worsening remodeling and reduction of LV function, plus hemodynamic alterations and salt and water retention. Finally, the patient, after many years of being subsymptomatic or subclinical, develops overt heart failure. Now, heart failure is a state of very aggressive neurohormonal imbalance. The RAS and natriuretic peptide active systems are counter-regulatory mechanisms in heart failure. In the presence of normal myocardium, natriuretic peptide is constantly secreted. However, when the myocardium is thin, damaged, or fibrosis, it can no longer actively produce natriuretic peptide. So we lose the benefit of vasodilatation, reduced sympathetic tone, fibrosis, and hypertrophy. On the other hand, RAS activation in an attempt to compensate and increase the afterload and stroke volume causes increased angiotensin II, which then causes vasoconstriction, increased sympathetic tone, fibrosis, and hypertrophy. So you have doubling of the RAS activation and loss of counter-regulatory NP production. So it really imbalances the system quite tremendously. And therefore, there is a need for combination of RAS blockade and natriuretic peptide inhibition so you can rebalance the system from both sides. At the same time, the effect of heart rate is very important because we know that long-term, regardless of your underlying cardiovascular disease, in chronic heart failure, an elevated heart rate requires increased oxygen demand, reduced efficiency, and difficulty in ventricular relaxation. Cardiac hypertrophy increases, and as that increases with more sympathetic activation, you're also going to activate the RAS. There's going to be progression of vascular disease, including endothelial dysfunction, worsening ischemia, whether the patient is ischemic or non-ischemic. There's increased oxygen consumption, reduction of diastole and coronary perfusion. So this is a vicious cycle that is activated by sympathetic activation and itself activates RAS blockade. Now, the relationship of increased heart rate in patients with heart failure and reduced ejection is very clear. Those patients with heart failure and reduced ejection fraction, when the heart rate is above 70, and 70 is a very critical cutoff point, versus those with the heart rate in dark black, less than 70, have an almost 30% difference in 1 year mortality and hospitalization. This is not a subtle thing, and it's really been hammered through in the guidelines as a very important physical finding we have to address early and at every visit. Now, this is the sympathetic activation, which we've sort of described in terms of the activation of RAS, more vasoconstriction, increased heart rate and contractility, and direct cardiotoxicity. So sympathetic activation also acts on the heart rate at a different level as well. Now, this is how the heart rate mechanisms in the myocardium are regulated. And these are due to multiple channels. Now, we're very familiar with the beta-1 adrenoceptor. And of course, this increased the granular cyclase and cyclic AMP. At the same time, you have the vagal activity, which causes slowing of the heart rate and decreased AV conduction. And then finally, we have this unique channel. This is the sodium channel, or the IF channel, funny channel, which is blocked specifically by ivabradine. And this is only present in the sinus node. All of these other receptors are present throughout the atrial and ventricular myocardium, and they are related to sympathetic drive. Now, the ivabradine has this unique mechanism. There's no other medicine in this class that actually causes this diastolic potential, this slow upslope diastolic potential, to be delayed, reducing the diastolic slope, and therefore reducing the heart rate selectively only. There is no effect on systemic blood pressure or vasoconstriction. Now, coming back to our original construct of heart failure as a progressive disease, remember that at any stage of heart failure, in functional class 2, the patient can have sudden death in the early stage, in the late stage, and they can also develop pump failure once they continue to decompensate. So it really is important that even in your patients who are less symptomatic, to address guideline medical therapy at all points, and particularly as early as you can. And one of the important things that I'd like to highlight is that heart failure events can occur suddenly without warning, and sudden death or cardiovascular death is very common in functional class 2. And this is very important, even with no prior history of heart failure hospitalization. So your so-called stable heart failure patient can suddenly have cardiac arrest. And this is data from the Paradigm study, who died and experienced cardiovascular death as the first and only event in this group of patients that is very well treated. And also very important to remember that there is a lot of inertia in heart failure. Most patients who come to the heart failure with heart failure, 5% receive any change in their treatment plan, even though they have benefits from increasing or adding guideline medical therapy. So the mechanisms of fibrosis are multiple, and there are extra and intracellular fibrosis, but then you also have the myocyte hypertrophy and collagen deposition leading to fibrosis. With that, the commonest mode of death in functional class 2 patients is ventricular fibrillation and arrhythmic death. Non-arrhythmic deaths are significantly less. 85% of patients die suddenly because of ventricular arrhythmia. And this is really just a cartoon to show you that at any stage of heart failure, there's significant progression of the fibrosis that tips the balance forward. And the vulnerability of the myocardium in heart failure is dependent on time. The longer the patient remains with HFrEF and the more scar they develop, the more likely they are to have a sudden death event, because there's also other environmental triggers that can cause this ventricular function to worsen as well. So we'll go to the case. This is actually a case that referred in August 2018. It's a 47-year-old female with postpartum associated cardiomyopathy that was diagnosed many years before. She's had multiple prior admissions for acute decompensated heart failure, was actually transferred to our hospital because of progressive volume overload, ascites, and dyspnea. So she was actually in biventricular failure at the time. Now, her initial diagnosis was preeclampsia during her fourth pregnancy in 2013, and developed overt heart failure with reduced ejection fraction in 2015, but was poorly compliant with medical therapies. And also, this, for your review, was her medical therapy when she was transferred to us. Carvedilol 3.125, lisinopril 2.5, digoxin 250, even though she was in sinus rhythm, spironolactone 25, and a very large dose of furosemide, 80 BID. At the time, she was functional class 3, blood pressure of 95/65, heart rate 105, and the NT-proBNP of 6,783. She was actually referred to us for discussion of ICD and advanced therapy, LVAD versus heart transplant. So the patient stayed in the hospital for a very long time. She was really quite ill and required an inotropic holiday with milrinone. Finally, we were able to put her on some medications. And I won't bore you with the details of her admission, but she was finally transferred from the CCU to the ward on day 17, was gradually started on titrated to metoprolol 100 daily, ivabradine 5, valsartan sacubitril 50 BID, and the digoxin was discontinued. Upon discharge, her NT-proBNP had decreased to 788. So after maybe 20 days of therapy, 788. So we see these patients at 1 week and 2 weeks post-discharge. So first clinic visit, 1 week post-discharge, her blood pressure had actually increased, 105/68, and her heart rate was significantly less, 81 beats per minute. We increased the valsartan sacubitril to 100 BID, increased the metoprolol succinate to 150 daily, and kept her on the ivabradine and the spironolactone. The second clinic visit after 2 weeks of discharge, blood pressure actually was a little bit higher and better because you see the cardiac output is improving. 110/72, the heart rate 77. Valsartan sacubitril increased to 200 BID, ivabradine increased to 7.5, and the furosemide was actually decreased to 20 milligrams daily, and she was kept on spironolactone. So again, very important concept. Heart failure patient is not a passive water tank. You can generally get rid of or down titrate diuretics very effectively if you increase the GDMT and maximize the doses that improve the cardiac output and stroke volume and decrease the heart rate. So after third clinic visit is at 4 weeks post-discharge. The blood pressure is very well maintained, the heart rate 68. The patient is actually totally euvolemic, and we decreased the furosemide to 20 milligrams every other day, and we were able to increase the metoprolol to 200 milligrams daily and maintain the spironolactone at the same dose. And the echo was done 41 days after discharge, revealing an increase of the EF to 35%, improved LV diastolic dimension from 64 to 56, and this is 41 days, less than 6 weeks, and systolic dimension from 58 to 42 with markedly decreased MR, no further evidence of septal flattening or LV diastolic dysfunction, normalization of the LV filling pressures with an E to E prime of 9. The TAPC had actually improved very significantly. So and then 10 months after discharge, she's never been readmitted and on clinic visits as completely euvolemic with no signs of heart failure. The EF is actually completely normalized. I'm going to show you the videos now. And the heart rate was 62 beats per minute, blood pressure 118/78, the BNP 93, less than the 125 that usually rules out heart failure in the outpatient setting. So in case there was any suspicion on this case, here I'm actually going to show you side by side. This is directly from our single monitor. This is the same patient. I'm not trying to do anything unusual. This is her August 2018, and this is her September 2019 echo. Full reverse remodeling. And this is her 4-chamber view. Again, this is August 2018, September 2019. And mind you, this was long-standing LV dysfunction that was first diagnosed in 2015. This is not an abrupt cardiomyopathy or acute myocarditis. And again, showing you the short axis views side by side, and the change in the left ventricular end diastolic dimension with about 12 months of therapy. And you can see very clearly here, this was her initial EF, 17%, and now her final EF is around 55%. And there's a huge difference in the myocardial dimensions. So I'm just gonna stop for a second because I couldn't upload the videos. I have to upload them from a desktop. They're very large. Give me 1 second if you don't mind. It's a very impressive video. So hopefully you can see this. This is the same patient, side by side. Quite remarkable. I have another series of videos I will show you. This one. Okay. Are you able to see this, this screen here?
No, not yet. Yeah, now. Excellent.
I think it's fairly obvious.
Yeah.
The incredible remodeling this very fortunate patient has, I should say. Close this. And here we go. And again, just to demonstrate really a very large difference in her EF. So I'll come back to the slides, to the presentation. So then the question is, after all that, does she need an ICD? Well, she certainly doesn't need an LVAD, and I think we gave her a very clean bill of health, and we told her she does not need an ICD. So this is September 2019. Naturally, we've been following this patient very closely, and in order to sort of correlate all the data, we did a cardiac MRI in just before the COVID-19 lockdown, and her cardiac MRI quantitatively is 53%. She has mild LV dilatation. The volume is 142 mLs, but there is no evidence of LV dysfunction at this point. Now, what's the evidence behind this really impressive reverse remodeling? Is this just a, a unique case that Dr. Hani found in his collection, trying to make everybody wow? No, it's actually been well recorded in multiple clinical studies. So recently published last year was the Prove and Evaluate Heart Failure Studies. This is with valsartan and sacubitril, and they looked at changes in both aortic stiffness, hemodynamics, and changes in cardiac structural measurements in patients very similar to the paradigm study, functional classes 2, 3, and 4, EF less than 40%, and the duration of treatment was 12 months. So with valsartan sacubitril versus, versus placebo, which contained the ACE inhibitor, of course, there was a significant increase of the ejection fraction at 12 months by 9.4%, and the left ventricular end diastolic volume indices and systolic volume indices, again, significantly reduced. This is almost in the same level as we had seen with patients with CRT. And looking at the analysis of the paradigm heart failure and the atmosphere study, which was aliskiren, in those patients who received valsartan sacubitril or aliskiren, even those who improved their ejection fraction, these patients had an independent benefit of heart rate reduction. So I just like to, this was a recently published analysis of the heart rate. It's still an independent predictor. So even if you're on good dose of valsartan sacubitril, this is what happens if your heart rate is still not controlled on top of that. Your cardiovascular death rate is significantly elevated, and the blue, of course, is the heart rate more than 76, and green is the heart rate less than 63. So still very worthwhile pursuing heart rate reduction. And if you remember in the paradigm study, 93% of patients were on high dose of beta blocker. Similarly, the outcome of heart failure hospitalization is significantly reduced. So even if you're on the most powerful RAS RNA blocker, you need to address the heart rate very aggressively. And this is, again, very similar. If you look at those patients who had an improvement of the heart rate, these are the ones who had down to 70. These are the ones who had the most significant change in their CV death, hospitalization, and combination of that. So we'll come to the SHIFT study because there's also what's called the SHIFT echo sub-study. So this is another remodeling study that used ivabradine as their placebo control study on top of basic medical therapy. So this was a derivative of the SHIFT study. Again, the whole focus was to look at echocardiographic parameters and to look at the effect of the therapy on remodeling. Now, the baseline characteristics here are actually very good. You have very similar. Functional class 2 and 3 comprise most of the patients, and a lot of these patients are patients you would be seeing in your clinic with ischemic cardiomyopathy. Excellent use of beta blockers, ACEs and ARBs. So if you add the ACEs and ARBs, it's 97% and 92% of beta blockers and MRI. So very modern therapy, if you would. Now, this is, again, a very important finding. The patients in the placebo arm had a significantly higher left ventricular systolic volume index, and there was about a 30% difference in that. And compared to those patients who received the ivabradine on top of best medical therapy. So a significant change in the stroke volume index. And the ejection fraction, this was a secondary endpoint, again, a significant improvement in the ejection fraction from baseline to 8 months with ivabradine. Obviously no change compared to placebo, and a 2.7 point increase in the ejection fraction compared to placebo across the board. So from baseline to 8 months and between placebo and ivabradine arm. So again, remodeling is being caused on top of excellent medical therapy with IF blocker heart rate reduction, trying to achieve a heart rate less than 70. Now, those patients in ivabradine had a mean drop of their heart rate by 14 beats per minute versus the high-dose beta blocker 5.8 beats per minute. And again, a significant change of the systolic and end-systolic volume index by about 7 ml per meter squared, and we saw the change in the ejection fraction earlier. So the conclusion that heart rate reduction with ivabradine on top of excellent medical therapy and good beta blocker, achieving heart rates below 70, as was seen in SHIFT, has improved reduction in LV volume, ejection fraction, and therefore suggested ivabradine modifies disease therapy in patients receiving powerful background medical therapies. There is an additional benefit. Now, what about combining beta blockers and ivabradine? How can we use this to optimize medical therapy? So here's my second case. This is a 32-year-old military officer, actually referred for an abnormal ECG that showed LVH and LAE. He had an echo, EF was 29%, and the NT-proBNP 2,139. He's actually referred for an ICD. So at the time we saw him, his blood pressure was 98/64 with a heart rate of 61 beats per minute. And so he was referred from a heart failure doctor, so it was good medical therapy. So he was on bisoprolol 10, ivabradine 5, sacubitril valsartan 200, spironolactone, and no diuretic, because honestly the patient was asymptomatic. So his initial echo, this is the May 2019 echo, and you see his ejection fraction of 30% and clearly dilated LV. And then October again, the ejection fraction has essentially normalized, 54%, normal dimensions on this side. So with that being said, again, just for comparison, this is the short axis view on the May and the short axis view after treatment. So I'm sorry, I'm gonna see if we can get the videos back for you. We have time, 1 second. Are the videos visible?
No.
Okay, 1 second. Let me just change the...
Yes.
And there it is. So this is the military officer, not the young lady. I know it looks kind of similar, but I tried to put them side by side so the difference is very clear. Let's play that one more time. So, okay. So the combination of the ivabradine and beta blocker was actually studied in a study that was published presented in ACC about 4 years ago. Smaller group of patients, but this is what happened. If you actually put the patient on carvedilol alone and maximize the dose, the 6-minute walk test was actually less than using carvedilol ivabradine. And the additional thing is, in fact, by using carvedilol and ivabradine early combination, you were able to reach more patients, were able to reach at least 50% of the target dose, 70% of the patients, apart from using carvedilol alone. Because the issue with carvedilol, as we all know, is that we're all going to have some initial decrease of the cardiac output and some tolerability issues. By adding both, you can actually improve the stroke volume and cardiac output, such as you can tolerate the carvedilol faster and use a maximum dose because you've increased the stroke volume and cardiac output very efficiently. Obviously, the ivabradine patients had a lower resting heart rate at 5 months than carvedilol alone, and that is the obvious therapeutic target. And in these patients, there was a significant difference in the LV systolic volume dimension and the left atrial dimension in the combination group. So to make it very clear, the combination of both is better than just titrating the carvedilol alone. And I think that sort of makes clinical sense because of its rapid impact on cardiac output, heart rate, and stroke volume, as we saw with those two cases. So my take-home messages, and I'm sorry I did run over time a little bit. Heart failure with reduced ejection fraction is a progressive lethal disease that requires full doses of combination guideline medical therapy to prevent sudden death and worsening of heart failure. Reverse remodeling is a well-documented positive benefit of optimal medical therapy in HFrEF, and remote and reverse modeling has been shown with evidence-based medicine to be a property of RAS blockers and ARNI at target doses, sympathetic inhibition with beta blockers at target doses, and also independently heart rate reduction to less than 70 beats per minute, preferably to 60, with IF receptor blocker with ivabradine. And thank you very much for your time.
Thank you very much, Dr. Sabbour, for this excellent presentation. I think you presented very well the combination of pathophysiological of heart failure and the importance of reverse remodeling. And I think really thank you for Dr. Ahmed Al-Masri and Servia for getting the two excellent speakers for this session. I think we'll have a time to take a few questions. So the first question is, what are the particularities in the athletic heart? Dr. Sabur?
In the which one?
Athletic heart.
Athletic heart.
I'm not sure why he put this question, but
So athletic heart, I think maybe Dr. Ala can answer this in a little more detail, but the difference between athletic heart and HOCM is important because you're going to have, for example, an athlete who plays for a sports club who has a screening echo that shows a thick ventricle. Now, if it's HOCM, you have to stop them from exercising. And if it's athletic heart, you have to allow them to possibly decondition and repeat. So I think it's clinically very important, but the echocardiographic features are quite distinct. And in HOCM, I think the gold standard is now the cardiac MRI, right? With the cardiac MRI, we can actually see if there is delayed enhancement, and that really helps us to determine what's going on. But I'll leave the answer to Dr. Ala.
Ala, please. You are mute, Ala. Unmute yourself. Thank you.
Okay, you hear me now?
Yes.
Yeah, okay. For athletic hearts already by the echo, there will be normal diastology. But for the patient with HOCM, there will be impaired diastology, mainly it could be decreased ejection fraction, and the diastology will be restricted pattern or already grade 1 or grade 2 diastolic dysfunction. In addition, also for the cavity. For patient with HOCM, there will be reduced LV cavity. But for athletic heart, it will be normal or little bit increased cavity. So it will, as Dr. Sabur said, this athletic heart, we allow them to continue their sport, but for the HOCM, we are preventing them to do competitive sports, which is very important.
Okay, Ala, second question for you is asking how much and how frequent image quality affects the calculation of GLS?
Image quality is very important from the beginning to do strain or strain rate or even for 3D echo. It must be the basic image quality must be the basic one will be very clear. Because already if it is not clear from the start, it will give you wrong message and wrong calculation. That's why it must be a very clear, good window to do this study.
Thank you. Dr. Sabur, he's asking you after normalization of left ventricle ejection fraction, for when and how you'll continue the medication, and are you going to taper it or try to stop it?
So this is a very important concept. So for the first patient, it's definitely long-standing cardiomyopathy. So I think once the ejection fraction normalized, there was actually no evidence to down titration. What we did with this lady is I actually got rid of her diuretics completely, okay? And we're doing serial echo. So clearly the patients who develop cardiomyopathy and HFrEF are at a different phenotype, genotype than patients who are not, right? So patients with MI, for example, don't all develop severe cardiomyopathy, right? So there is very limited data on recovery. You've seen some of it. This is the published data. There's also some data in registries about recovery, more from coming peripartum cardiomyopathy. So those is the only group of patients, peripartum cardiomyopathy, the ejection fraction completely normalizes and they don't have another pregnancy that you can down titrate or reverse medications. It's been shown from a recent registry that was presented at ESC last year that patients who down titrated their beta blocker after recovery had a 40% relapse within the next 2 years. So I think the data is there that these patients have to be told you have a cardiomyopathy. This is not a reversible cardiomyopathy. You have to be on the medical therapy, and we have to be very careful about these people because for some reason or other, they are susceptible to recurrence. It's not like a normal myocardium. Yes, it looks functionally normal and it does obviously appear very impressive, but we have to be very cautious. So I would say based on the current recommendations of guidelines, no, do not down titrate, but you can get rid of diuretics very efficiently.
Thank you very much, Dr. Sabur. I have just a clarification. One of the question, he's asking, can you explain more about what you mean by theory of water tank?
Yes. So I wanted to make this very clear, and I wasn't trying to be funny, but I think people will remember this water tank for a long time. When we see patients referred to the heart failure clinic, so I have a heart failure clinic and an electrophysiology clinic. Most of them are on big doses of beta blockers and small doses of guideline medical therapy. Why? Because doctors are more afraid of what's going to cause the patient to have symptoms, right? Which is water. Diuretics eliminate fluid. But according to every guideline, there is no benefit of diuretics. Diuretics have no impact on mortality, morbidity. If anything, they can make the CKD aspect worse. So what I want people to focus on, and this is the take-home message, if you see a patient on big doses of diuretics, that's only going to eliminate the preload aspect. It has no effect on RAS, has no effect on sympathetic activation. It will certainly not improve remodeling, and it will have no effect on the afterload, right? And in fact, it may lead the patient to become diuretic resistant. So the most important thing when we are discharging patients, the first thing we do on rounds, we look at the patient's leg, we look at the neck, we look at the lungs. Lungs are clear, mabruk, we're gonna stop your IV Lasix, give you an oral. The decision point actually should change to, I'm gonna give you another 24 hours to put you on RAS blocker, switch you to ARNI, add the beta blocker before discharge, right? So while we have become extremely expert as cardiologists in volume management, we need to be more expert in GDMT initialization and GDMT titration and follow-up.
Great, thank you. Another question for you. When should we start the combination and which patient group?
So,
beta blocker and fibradine, he means.
Yes. So technically speaking, you are looking at the post-discharge period because the SHIFT study started in post-discharge patients. However, you all have seen patients that sit in the hospital for a long period of time, and you are struggling with the beta blocker for some reason or other. So it's clear that if you're looking at the first 30 days post-hospitalization and the first 2 weeks post-hospitalization is the most critical period for these patients. Now, the recommendation of the guidelines is very clear. You have to start with the beta blocker and the MRA, and some of us now are using ARNI de novo. We're not waiting to go through a period of ACE inhibitor because that's been shown from the prove and evaluate and titration and initiation studies not to be necessary. Patient is euvolemic, you're gonna start them with a certain dose of ARNI, make sure they're on a good dose of beta blocker before discharge. See them after 1 week, look at the heart rate. Within this 1 to 2 week period, if the heart rate is still elevated, while you are titrating the beta blocker, add the ivabradine, because we saw from the Bagri study from the ACC that if you do that early, you can reach the target dose of beta blocker, higher doses, quicker within a shorter period of time. Because the combination of beta blocker, ivabradine, RAS blockade improves the stroke volume, the cardiac output increases, therefore you can titrate even more medication. That's the whole additive benefit of these hemodynamically acting therapies. So I would say as early as possible. And when we see the current guidelines, you're going to see that they've already moved valsartan sacubitril to in-hospital initiation in treatment-naive patients or in patients who have failed prior ACE inhibitor and ARB.
Thank you very much, Dr. Ala.
Yes.
GLS, will you do it before starting chemotherapy in oncology patient?
Sorry?
GLS, global inclusion strain for oncology patient.
Yes. It is already used for the patient mainly before and also after for the follow-up of the patient with chemotherapy to see already the effect of the drug on the myocardium, because it can cause early detection of the left ventricular dysfunction before it becomes more clinically or more obvious by the 2D echo. So at the beginning, we are before starting the chemotherapy, and also with the follow-up of the patient after starting the chemotherapy. It is important.
Okay, thank you. Dr. Hani, the question is, there is a particular beta blocker that you think will work better with ivabradine, or all beta blockers are the same?
So there are actually only 3 beta blockers that are licensed and indicated for use in heart failure and reduced ejection fraction. Carvedilol, because of the US carvedilol studies, and then Copernicus, of course, for very low ejection fraction. Bisoprolol, which is super selective and long-acting. This is from the CBIS-1 and CBIS-2 studies. And Toprol XL, which is metoprolol succinate extended release. This is not the short-acting low pressure. I'm going to make this very clear. The long-acting extended-release succinate was studied in a specific study, Merit HF, and this is the difference. So you have to use those three. You will have to select them based on different items. They all work very well with ivabradine. They've been all independently studied. The point is you have differences between the three beta blockers, right? In terms of metabolic neutrality, right? In terms of selectivity, so side effects in young males, very important point, right? And in terms of duration of action, once a day versus twice a day. So those are sort of individual decisions for your patients. And of course, if they have atrial fibrillation, remember that carvedilol, you cannot use ivabradine. Carvedilol has a lower effect on the heart rate than bisoprolol and metoprolol, right? So if you have a faster heart rate, you might want to be reaching for your carvedilol or bisoprolol than carvedilol.
Thank you. The question was related to your pregnant patient.
Yes.
Will you allow her to have another pregnancy being a normalized ejection fraction?
So the reality is this patient, we had this long discussion with her and her husband. So her last pregnancy was 2015 and the one before that was, 2013, and she had the preeclampsia. So I don't know what is her genetic substrate. And we did the cardiac MRI and she doesn't have late enhancement. So this is a pure non-ischemic cardiomyopathy, what is non-familial. We would strongly recommend against pregnancy in this particular lady because she is on maximum medical therapy. And of course, as you know, during pregnancy, we would have to stop everything except beta blocker. We'd have to eliminate the valsartan sacubitril. So with this discussion, we counseled against it. Of course, we can't force the patients. We just give them the evidence-based medicine. It's one of the likely things that could happen with her is that she can decompensate severely during pregnancy. And in patients who have peripartum cardiomyopathy, the second pregnancy is often fraught with danger. So you have to be in consultation with the obstetric maternal-fetal medicine people. I would say no.
Okay, he's asking about the heart rate and nebivolol.
Yes. So this is an interesting point. The nebivolol is a selective beta blocker with nitric oxide donor property. Okay, it's almost like having sildenafil attached to the beta blocker moiety. So this one has only been studied in a small group of patients called the senior study, which included patients largely with heart failure and preserved ejection fraction. So we cannot utilize this drug in reduced ejection fraction. This is not in the guidelines, it's specifically mentioned. The effect of heart rate with this drug is somewhat attenuated. It's more of a vasodilator than vasodilatory beta blocker than its heart rate effect. So I generally restrict its use in males who have hypertension or males who have sympathetic overdrive or patients with coronary heart disease or elderly patients with HFrEF. It's not really indicated in this group of patients with HFpEF, I mean. It's not indicated in patients with reduced ejection fraction.
Dr. Ala, back about GLS, when you were started after receiving chemotherapy?
Already, as we are doing follow-up with the patients with the chemotherapy, already after the cycle of the chemotherapy, after each cycle, we are doing the echo, normal echo, and also looking for GLS. It is the same, it is decreasing or like this for the detection of any effect on the myocardium. If it is okay, at the end, after finishing the cycle, will be follow up after that with the normal echo to see the ejection fraction if it is already no changes in the GLS during the chemotherapy.
You mean by the cycle, the full course, right?
Full course, yes, yes.
Okay, good. I think we answered the majority of the question. I think it was an excellent presentation by both of Dr. Alaaddin Khalil and Dr. Hani Sabbour. And I'd like to thank the audience for really this excellent participation and joining in this seminar. I'd like to thank Dr. Ahmed Al-Masri and Servier for really getting us together in this excellent meeting. We hope to see you soon, inshallah, and thank you very much. Assalamu alaikum.
Thank you very much for the invitation.
Thank you, Dr. Hani.
يديكم العافية، نشوفكم على خير يا رب دائما. سعيدين برؤيتكم ويديكم العافية. ولدن ما شاء الله تبارك الله. ولدن.
الله يكرمك. مع السلامة.